Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Tonight's topic is Pediatric Pharmapalooza. Our guest speaker is Dr. Nidhi Rana, who got her optometry degree and her master's degree in clinical optometry from Pacific University's College of Optometry. She completed her pediatric residency from Illinois College of Optometry as a fellow of the American Academy of Optometry. He currently works in a private MD/OD pediatric specialty practice in New Jersey and at the Wills Eye Hospital in Pediatric Ophthalmology Department in Philadelphia. Her specialties include treatment management of amblyopia and strabismus in pediatrics, specialty contact lenses, including aphakic fittings and genetic conditions in pediatrics. She lectures both nationally and internationally. We've worked with her many times, and we've been always very thrilled with the information that she brings in a very unique perspective and a great presentation style. So please give a nice warm OEC welcome to Dr. Nidhi Rana.
Am I good to go?
Good to go.
All right. Well, thank you, everybody. I have to thank Joe and Greg a lot because when I first started lecturing, I kind of really started with lecturing with them, and that's helped me move on to many more lectures. So I will always be thankful to them. Those of you who have been to my lecture before, welcome back. Thank you for coming. Those of you who haven't, welcome. Like they said, I see only pediatrics. My youngest would be a newborn, and after 18, I really kicked them out of the office, so we don't see them anymore. So without further ado, let's get started. Those are my three babies. I had to warn them not to come upstairs while I'm doing this, so they keep me in line. I have no financial disclosure to make. That's my email, drnidhirana@yahoo.com. Please feel free to email if you have any questions, if I can help with anything. It would be my pleasure to answer any questions if needed. So getting back to our lecture, kids use systemic medications, as we all know. We're going to talk about a few different things while we're doing this lecture today. 5 to 7% of there's worldwide prevalence of adverse drug reactions in pediatrics. Many of them are serious, up to 17% in hospitalized children. This is why we need to be aware of what we're doing and when we're giving medications to these kids. Pediatric adverse drug reactions in neonates, they are at higher risk because they're smaller kids. And 58% of these reactions are serious and fatal for many of these children. At least a third of them can be avoidable, and that's kind of why we need to really know our medications when we're prescribing them, or understand when they are on some medications about the interactions that's going on in their bodies. 1 out of 5 kids are prescribed at least one drug per outpatient visit, which is a lot. 7.5 prescribe 2 or more drugs per visit when they go to the doctors. About 50% of drugs, when I was looking through statistics, I thought this was pretty interesting that 50% of drugs in the US are not approved for children, FDA approved, but they're used as off-label uses. And we all know that because FDA going through that process in the United States is much more vigorous than it is in the other countries. So that makes it much harder to do FDA approval here. Why are we talking about prescribing medications in kids? Well, the important key point to know is they have altered pharmacokinetics. So that's immature pharmacokinetics that they have. Their absorptive surface maturation is not fully developed when they're younger. Their gastric pH is much higher. So when the medicine is just sitting in their bellies, it's going to work differently than it is for you and me as adults. Their emptying times are lower in kids. So again, the medication is just going to be pulling there. Their renal function doesn't mature till the age of about 1 to 2 year olds. So the younger children, when they're prescribed medications, should be prescribed with a lot of caution because they don't have great renal function at that age. Liver metabolism, same thing, it matures over several years. And again, The reason we need to know that is because a lot of the medications that we prescribe are excreted through the kidneys, they're metabolized in the liver, and that's important for us to know when we're prescribing these medications in our little ones. The body water decreases as they get older and the fat increases with age. So some of these medications also will work similarly in those conditions. I don't know about your office settings, how they are. I work in a hospital and office setting. So in the hospital, we have our fellows and our residents. If I'm not having my private clinic, they'll see the patient and then I go in and then I go in as an attending and help them. In the office setting, our office techs don't do much in the office. They bring our patient in, they take a good history, and that's about it, and keep everything ready for me. Say if I'm seeing an abrasion, keep my split lamp, handheld slit lamp ready, fluorescein strip, so on and so forth. So our techs don't do much, and we like that only because you and I know that if you're seeing kids, you have only like 10 minutes to see them before they lose their attention span. And I think that's kind of why we don't let our techs do much more. So good history taking, like any other adult patient, is important. Why they're there. They have some red eyes or discharge or what else is going on with them. A good birth history is important because we see pediatric kids. Family history is important. If they have wear glasses, amblyopia, strabismus, we know that runs in families. So that's why it's important for us to know that. Medications, what medications they're on. So that way, when we do prescribe any medication for them, we want to make sure there's no drug reactions happening there. Allergies to medicine, simple. If they're allergic to a medication, we're going to obviously avoid that. A good medical history is important in kids as well. And I've highlighted a few things there. Kids have asthma. So 1 in 12 kids, which is 6 million kids who have asthma. So that's important to remember. They do have, you want to make sure they do not have any GI issues, ulcers, watch their liver function. Remember, their liver function is immature and the metabolism is still developing. Kidney function is crucial. Again, those little babies, if we're giving them medicines, you want to be very aware of that. G6PD is glucose 6-phosphate deficiency. Kids with that condition, you want to avoid sulfa medications for them. The condition is also called favism. It's about 400 million kids or adults who have it, and you want to avoid fava beans for them. These kids have a certain enzyme in their body that doesn't work quite right. And these kids, so this enzyme is in the red blood cells. It doesn't work well, and it can cause aplastic anemia if they have sulfa medicines or fava beans and many other different things that are on the list. History of seizures is important. We prescribe, as you know, cyclopentolate eye drops in little ones. And there are a lot of research that supported that the kids who had seizures already, if they were given cyclopentolate eye drops, you have the risk that it can trigger the seizure for them. So that's why you want to avoid it in those kids. Eczema and atopy has become more common in these kids, at least in the last decade of working. I'm going to be practicing for almost 20 years, and I feel like in the last decade, I've seen this trend where the eczema and atopy in kids has definitely increased. So about 20% of kids do have that as well. You want to know the weight of the child, especially when we prescribe oral medications. And lucky for us, we've got to do an extra math. So 1 kilogram is 2.2 pounds. And most of the medications are given in milligrams per kilogram per day. Also, when you prescribe medications, this is very logical, right? You want to find the right drug, what you want to prescribe for the kid. You want to find the way you want to prescribe it. For us, we're limited to giving topical, orals. Of course, there are other routes of administration like IV, intramuscular, subcutaneous, and so on. You want to find the right dose, the right time of duration you want to give it, 5 days, 7 days, 10 days. So that's important to know as well. Want to choose between ointment drops or if you're doing topical medications. Brand name versus generic is important because we all know that generic is a lot cheaper than brand names. Self-preserve or preservative-free medications that would work with whether a child has a chronic condition you're treating or an acute condition. Of course, in an acute condition, you can use anything, but in a chronic condition, we always try to use things that are preservative-free to just help with those. Just to highlight a point here, between ointment and eye drops, I tend to use eye drops a lot more. I feel I use the ointment usually at night if I want to give coverage overnight to the child, or if I'm doing, if I'm patching them, they had an abrasion, I put the ointment in, patch them, and then I'll see them next day. That's when I use the ointment. Remember, with the ointment, especially for older kids, they'll be blurry the next morning, which many of those kids don't appreciate. So I'm not a big fan of ointments in general, but I like the eye drops better. Children over 12 years old or can be dosed as adults or over 100 pounds. I want to highlight that weight is always important in prescribing when you're prescribing oral medications for children, because an 8-year-old could be as big as 100 pounds and can be given an adult dose. A 15-year-old could be a very small kid and not quite yet 100 pounds, which they would be underweight at the time. But in general, my point being is that the weight is important to keep in mind. And of course, we prescribe oral medications as milligram per kilogram per day, which we'll talk about in a teeny bit. Okay, so when I had started prescribing medications, I remember, I'm very lucky that way. I work in an MD/OD practice. So initially in my practice, when I was prescribing oral medications, I would just ask my MD, partner, whoever was in the office, and say, oh, I'm seeing a preceptor, I want to give antibiotic, and they would help me out. In times when they were not around, I would just call the pediatrician and say, I see a preceptor, I'd like to give them the antibiotic medication, this is what I want to give them, and they would help us prescribe it for the kid. Now that I've done it for so long, it's much easier. So my clinical pearl would be is don't hesitate to ask the pediatrician. They're really very helpful many of the times. There are some who are not, but most of the time they're very helpful to help you out. The other way to do it is if you are in a practice where you're co-managing, is to write it out yourself, like do the math, which I will go over one example in a little bit, and then show them and say, well, I want to give them Augmentin. This is what I wanted to prescribe. Do you think that's appropriate? And that would also boost your confidence of doing it. In the end, you want to work for the patient's benefit. So working together as a team is super important. Remember, we are advocates for those little ones. I love my little ones. I love my little babies that I see all day long. I have no patience for adults. I could see nobody over the age of 18, not at all. Okay, so we're going to talk about most of these medications, some systemic medications. So let's get moving. We want to know the common pathogens or the bugs that that we see in kids. Gram-positives, your bacteria, the staph, the strep, are very common that cause conjunctivitis and cellulitis in kids. Gram-negative, you have the Haemophilus, which causes many times the orbital cellulitis. You've got MRSA, fungus, viral, anaerobes, which are the bug bites that can cause cellulitis in kids. Kids are prone to get anaerobic reactions like bug bites, and they're out and about, especially in the summer. We see tons of these kids who get preseptal because of these bug bites. So you want to keep that in mind. Most of the antibiotics orally that we prescribe come under the bactericidal kind of family of antibiotics. They directly kill the bacteria, your aminoglycosides, fluoroquinolones, your penicillins, your cephalosporins, which is great. That's what we need. The bacteriostatic antibiotics, on the other hand, just stop the bacteria from growing, and your sulfamedicines, trimethoprim, some degree of erythromycin, and tetracyclines fall under the bacteriostatic medications. But most of what we use kills the bacteria. So we don't necessarily, and I don't know about many of you who do go ahead and prescribe antibiotics or see children. I pick a broad spectrum antibiotic only because day to day, I am not culturing these little ones. I would be happy if we just had a good exam and they were not screaming bloody murder, right? So in that case, I feel like culturing is very, very uncommon. I probably culture one of this maybe once or twice a year, so it's not very frequently that we do that. So using a broad spectrum antibiotic for that reason is a good way to cover all our bases. So I like to do more case studies only because I feel like I learn better that way. So that was more just the pharmacology side of it. So let's get into a little more case study so we can see more about the prescribing stuff. 5-month-old comes in with crusting of the lashes, been going on for a week now, some redness in the eyes, some puffiness, some watery discharge. Kid is healthy otherwise. If you look at the anterior segment, you see some extra tearing in that eye, a little bit of fluorescein staining there. Cycloplegic refraction is normal, and the fundus looks healthy. Now, I do a full exam where I can because the population of children that we see at the hospital come from the suburbs. Many times when we see these kids from the burbs, you're not going to see them back. So I like to do most of what I can. Now we use our logic there also, right? If the eye is falling out, I'm not going to want to do a refraction on that day. That might be not as important. So of course that becomes more logical. But if I can, you'll see most of my cases that I would have done a full exam where I can. In a kid who has nasolacrimal duct obstruction, like in this little one, you want to do a cycloplegic refraction again, if it's possible. There's a lot of research that shows that kids who do have nasolacrimal duct obstruction can have one smaller eye. The eye that has the duct obstruction can be smaller. And remember, in our age group that we're seeing kids in that first decade of life, amblyopia is very prevalent in those kids, or possible, I should say. And I don't want even one of our kids not seeing as good, because amblyopia is preventable. If you find it, you can fix it if they're very young, right? So looking at that is important. So nasolacrimal duct obstruction, that eye could be a smaller eye, and then depending on the difference, could be amblyogenic in nature. So that's one key point to remember. This is our lacrimal apparatus, just to give us a little review. You've got your lacrimal gland, you've got your lacrimal sac, then you've got your lacrimal duct, and of course, that's our how the lacrimal apparatus is. The duct obstruction is also called dacryostenosis. The canalization of the nasolacrimal duct should be complete by the age of by 8th month of gestation. Up to about 20% of kids can have, newborns can have the duct obstruction. It's commonly seen in a pediatric practice. It's because the valve of Hassner, where it's on the bottom of the duct, doesn't canalize and doesn't open up, that epithelial cells are still, there's a layer of it. Because of that, pulling off all this tear just happens. And the more the pulling happens in the sac, you know, bacteria loves all that gunk, right? And that causes these infections for these little ones. The good part is that 90% of them can resolve by the age of about a year, a little over a year, so almost till about 14 months or so. So you just treat their accompanying symptoms. You don't have to do anything much from there. I always tell the parents, clean the eye with some warm water. We'll watch it. 90% of them resolve, so why want to do anything? The hydrostatic massages, I had to pick this picture just to show how hard it is, that even this picture, the kid is screaming bloody murder. And everybody has a different way of explaining what a hydrostatic massage is. And it's very interesting that when I'm with my colleagues, you know, other pediatric ophthalmologists or pediatric trained optometrists like myself, we all have our different pet peeves of how we want to do the massage. I like to just put it this way and say, we want nothing in the sac. So if we push on the sac and the duct and then take that gunk out, once the gunk goes out, you have less risk for the bacteria pooling in there, and the more the reason of not having any issues with it. Nobody is happy with it. One of my little ones, maybe my middle one, he used to have a nasolacrimal duct obstruction as a baby. And boy, doing those massages firsthand was no joke. He would scream bloody murder for it. I like to use Polytrim, and again, I have no financial disclosures. Like I said, I like Polytrim eye drops. I use them twice, thrice a day for a few days just to clear that infection out. I like the bacitracin ointment too. If I wanted to do an ointment, again, a few times a day, 3-5 days, and you're good to go with those. We only consider probing if that nasolacrimal duct obstruction doesn't get better after the age of about 14 months. or if this kid has recurrent infections. So some of our kids who have Down syndrome almost always have the duct obstructions, and they almost always will continue having one after the other recurrent infection. Hate to put those babies on medicines more often than needed. So in those cases, we do consider probing those children much ahead of time, and then they would consult with our pediatric ophthalmologist and go from there. Okay.
Hey, Nidhi,
Yes.
there is a, I don't know, a recall, not a recall call, but there's quarter shortage polytrim, which is great for children. What would you recommend if someone had the call that says, hey, polytrim is on back order?
If they are, you could use the ointment, or you could do, actually, we're going to talk about that. So if we continue, we're going to talk right about those different types of topical antibiotics right here. So I'm just going to go over those. So you can use the bacitracin, just like Greg said. If polytrim, nobody has polytrim. So let's go. We have bacitracin ointment. It's good for gram-positive bacteria, which kids get. It is generically available, so it's cheaper. Like I said, I don't like ointment, but in many cases, if that's what's there, then that's what's there. They work fine. You can do polysporin, which is also an ointment, and it covers both gram-positive and gram-negative. And like I had mentioned earlier, gram-positive and gram-negative is good to cover, just because you never know what the kid's having. So staph, strep, and all, you want to cover, and Haemophilus and stuff. So this polysporin is a great choice. Neosporin also works great. It has bacitracin, polymyxin B, and neomycin in it. I'm not a big fan of Neosporin, the neomycin part of it, only because that can cause a type 4 delayed hypersensitivity reaction in about 5 to 10%. Again, if nothing else is available, that could be a choice, and you just take that small risk that you could have that delayed reaction. But in most times, that medication works perfectly fine as well. Like I said, my go-to in younger children is polytrim. It's a great eye drop. It's used on very young children. It covers strep, it covers Haemophilus. It's a great eye drop otherwise. So I tend to use that eye drop way often in my little ones. The erythromycin is great as well. It covers gram-positive and gram-negative too. And it is used for newborns, for newborn conjunctivitis, neonatal conjunctivitis in the hospitals. Azithromycin is a great medicine. It's a macrolide. It is wonderful because it has a prolonged intracellular life, which means the drug can stay in the eye for a little longer, so you can dose it less frequently. The problem with it is it's expensive. So many of the times the insurances don't cover it. So unless I have some samples, that's not my really go-to medication in a big picture. You could use your aminoglycosides like gentamicin, tobramycin, neomycin, and like I pointed earlier, neomycin kind of family of those medicines are not my favorite. One, they cause that delayed hypersensitivity reaction. They're not used systemically because they cause ototoxicity. Gentamicin is not used as much because it causes epithelial toxicity. So out of all of them, if I was going to pick one, I'd probably pick tobramycin. That has the least epithelial toxic response in kids. And it's used very young, so it's a good drop medicine to use. It's concentration dependent, which means you have to dose them more frequently because they kind of wear off fast. So these drops, we normally dose them at about QID, only because you want more coverage in the eye. Also, because they are concentration dependent medicines, you have to dose them for a longer period of time to get the same effect that you could get with the other eye drops. So again, not my favorite set of drops, but still does the work if you have nothing else to use. The fluoroquinolones are my big guns. I don't usually use them unless I'm really treating something big going on in the eye, like an ulcer or contact lens related stuff. Then yes, I use my fluoroquinolones. But in normal garden variety stuff, the other medicines work great. I do use Cipro and ofloxacin pretty often because, again, they are the least that could cause more issues. The rest of them, really, I only use it if needed. And in our younger population, we don't use them quite as often as you would in your older children. So let's move gears to a 4-year-old kid who's complaining of swelling that's going on for the past 2 days. Mom says it's getting worse. The kid has no fever. She's doing great, some discharge. Healthy child otherwise. Vision's great. Eye looks good. Some tenderness when I touch that upper eyelid. And she's had a chalazion going on for a few weeks. So upper and lower eyelid, when I touch, she was having some pain. You can see the redness on that left side. Retinoscopy looks great. Eye looks healthy otherwise. So we all know that's a preseptal cellulitis. So what would I first do if this kid has chalazion? Again, I wanted to point out important points, right? You're looking for amblyogenic factors, especially in that first decade of life when your babies are really little. So I'm going to look if this kid has, this kid's picture has multiple chalazia, but if they have one chalazion in one eye, I'm looking for induced astigmatism because as the chalazion is pushing on the eye, it can change the shape of the eye and cause more astigmatism in one eye than the other. So again, red flag, amblyogenic in nature. But otherwise, I tell the parents to keep the lids and lashes clean, do a lot of warm compresses if they can. Again, with younger children, we all know that it's easier said than done, right? So the most they can. Very seldom we get them removed because again, these kids have to be put under anesthesia to remove them. So less likelihood that we're going to do that. So we try to stick it out so that we can do other stuff. We do give them medication. Sometimes I'll give them a combo medicine of steroid and antibiotic if it's really inflamed and they're irritated by it. So short-term use of a combo steroid, I do many times. Moving on to what I would do for a preseptal cellulitis. If I have to treat them something with topical, like I just said, I'll put them on polytrim if I wanted to, or I can do a combo of an antibiotic and a steroid, which can give them double that effect. Oral, yes, I'm going to put them on an oral medication. I like Augmentin. That's kind of my go-to antibiotic if they have no allergies to any penicillin. Augmentin can be flavored, so that helps with giving these kids some medication. Clindamycin, if I'm thinking of MRSA, then I'm going to cover it with clindamycin. Clindamycin has such a bitter taste that getting that down any kid's throat is not fun. I had to do it one time for one of my kids, and that was a battle. We couldn't really get much of that medication down. I probably didn't use the medicine at all. Okay, so in some cases you put them on both, but we know the treatment for preseptal is oral medication. Okay, so let's talk about our oral antibiotics. You have penicillin family of antibiotics. Amoxicillin is a synthetic penicillin. You have amoxicillin with clouvinate acid, which covers a lot of things. It covers gram positives, gram negatives. It covers anaerobes, the insect bites, which is very common in children. So Augmentin is a good go-to for the oral antibiotic in kids. Knowing their liver function, kidney function, just like any other adult is important. They do have side effects just from any other antibiotic like diarrhea, cramps, stomach pain, and so on. People who have penicillin allergy, what would you use? Macrolide or fluoroquinolone, or should we use a cephalosporin? I would say cephalosporins are used. My husband's a cardiologist, and many times we talk about, the cross sensitivity between these medications. And he does say that if there is no other stuff that you can use, then of course cephalosporin can be prescribed. But it's not something we should just prescribe. I think it's important to then reach out to their pediatrician. I think all these 20 years that I've been practicing, I want to say I had only one time that we did have to do cephalosporin for a kid who had penicillin allergy, which the pediatrician worked with me to do. And the kid was actually fine, but they took other kind of precautions to give them that medication. That was many, many eons ago. Clindamycin, if you're thinking MRSA, keep that in mind. And sulfa, the common one we use is Bactrim. So let's talk about an example of prescribing this medication, oral medication in children. So let's talk about a 40-pound baby, 5-year-old who has preseptal cellulitis. So first I'm going to convert 40 pounds to kilograms. Those of you who see pediatrics, another clinical advice is if you don't have a weighing scale in your office, it's good to have one, only because in kids, again, weight is important. And parents sometimes are right on it and they'll give you the right weight, and some of them have no clue the kid's weight. So that's important to know. Once you've changed it, it's 18 kilograms. Back in the day, I remember we used to look at Hippocrates and stuff to look at what medication you wanted to give. But now if you just Google and say pediatric dosage for Augmentin orally, you get all these different websites that can give you the dosage. So here it's 20 to 40 milligrams per kilogram per day in divided doses of 3 times or twice a day. Augmentin comes in 2 suspensions, a 125 milligram and a 250 milligram 5 ml suspension, which is dosed every 3 hours. It also comes in a 200 and 400 milligram per 5 ml suspension, which is dosed twice a day. So let's go back, 40-pound baby, which is 18 kilograms. I want to give 40 milligrams per kilogram per day. So 18 times 40 is 727 milligrams a day. You can divide it into twice a day, which would be 363 milligrams every 12 hours, or you could divide them into thrice a day, which would be 242 milligrams every 8 hours. Doesn't matter what you pick. I just happen to round the 242 to 250 because that's the suspension comes in that. So I said, all right, 250 milligrams every 8 hours. So that's thrice. So I would prescribe Augmentin by mouth, 250 mg per 5 ml suspension, give them 1 5 ml or 1 teaspoon every 8 hours for 7 to 10 days for treating preseptal cellulitis, no refills on it. So that's kind of a common way to prescribe. And the more you do these, the more comfortable you do get with them. It's not rocket science, it's basic math. You just have to know the medication, which you can Google, and then you'll be able to see what to prescribe. So going on from there, we have cephalosporins. It's the next medication from penicillins. It's closely related to them. We just talked about that. So in this nice cheat sheet, I like that the first generation medications have a great gram-positive coverage. And as you go up in the generations, they have better gram-negative coverage. So if I wanted to just cover like my staph strep, maybe I would go with Keflex. And if not, I could go with an Omnicef if I'm looking at more gram-negative Pseudomonas and so on. Macrolides are also used in these kids. Erythromycin is commonly used. You have azithromycin as well, and they have chlamydicidal properties as well. So if I'm prescribing it for our kids, this is another go-to medication as well. Fluoroquinolones orally are not really given in young children because they are mostly given to treat UTI infections. So I hope none of us are prescribing this in some way. And they may decrease cartilage and bone formation. So that's a big no-no to prescribe these orally. Sulfa medications, Bactrim is the most common sulfa medicine that we prescribe. Again, you want to avoid that in the kids who have G6PD. Liver disease, kidney disease, anemia patients. And that's really not the medication I use too often. I've noticed that the cephalosporins, penicillins, macrolides maybe are probably the most common ones that I tend to use in our little ones. Okay, tetracycline is great. It stops bacterial protein synthesis. It is not used in children less than 12 years. There is some research that says maybe less than 8 years. It doesn't matter. Somewhere around there is what you should not use it, less than 8, less than 12. Because it's linked to pseudotumor cerebri, kids can have tinnitus associated with it. Tetracycline in many older kids, like, your 15-year-olds, 16-year-olds, are used as an acne medication. So you want to watch out for any risk for pseudotumor cerebri. Photosensitivity in children. The younger children will get yellowish staining of the teeth. So tetracycline is not a great medication for the younger population. In adults, we know, or the older children, we know it's a great medicine to treat blepharitis, acne rosacea. So it's a good medicine, except not the little ones. So let's move on to another case. We have a 4-year-old whose swelling is getting worse, eyelid is shut. They came to see me complaining of pain, fever, lethargy. tried to do his vision, 20/40 in that eye. If you look at the eye, there's so much swelling. That would be an orbital cellulitis. Kid cannot open the eye, kid's not doing great. So what am I going to do for that? Not going to treat them. I'm going to send them over to the ER. I love to call the ER doctor as well. I just don't tell the patient, all right, see you later, go to the ER with no other information, because many times then they get to the ER. If they get to the ER, I've had people who disappeared and did not go to the ER, then I have to hunt them down. So I've had that also. So if they go to the ER doctor over there doesn't know what's going on. They might call a pediatric ophthalmologist who's on call to go through the whole stuff that I already did. It's just a waste of time for the child. It's better to just call the ER doctor if you can, or write them a prescription and say, take this to the ER doctor when you get there, and they should know what to do. I write on their orbital cellulitis of the left eye, do a CT scan, please give them IV antibiotics, and then they pretty much know what to do and go from there. Sometimes if they need topical antibiotics, they'll give them those as well. They would start off with giving them IV antibiotics in the hospital, admit them, give them the IV antibiotics for a couple of days till that swelling gets better. And then most of these children are discharged with an oral antibiotic to finish at home. And of course, we talked about a CT scan or an MRI. So I put this little quick cheat sheet just to give us a reminder about dividing preseptal and orbital cellulitis. It's very important to keep this in mind for younger children. Preseptal has not much going on. There's swelling, but it's not affecting the vision. Some warm lids, the kid's not lethargic, no fever. And you can see an obvious cause for the preseptal because it's in front of the eye. So bug bite, chalazion, maybe a localized trauma. They had a laceration on the eyelid, and now that's all full of gunk and bacteria, localized inflammation, maybe post, some lid issue going on. The orbital, on the other hand, you'll have a number of things affected. VA is affected, more fever and lethargy, EMs are restricted, and the causes are more deeper. So a sinusitis or a worse preseptal or an abscess behind the eye that can then go travel to the brain. So that's important to keep in mind. I put an asterisk on the pupils because I'm looking at it in my 3-year-olds, 2-year-olds, 5-year-olds. I'm not great at looking at their pupils when they're already screaming. If you can do it, good for you. That's an extra piece of information to help. I'm not that great at doing it. If I'm lucky one day, yes, I can see it. But on a normal day-to-day scenario, I can bet you it's pretty hard to look at that part. So I don't look at it that carefully. I like this slide a lot because a lot of times my residents that see the patients in the office when they're looking for preseptal tell me a few things. So if you look at this chart, I love this chart, like I said, when the kids are really little, only their maxillary and ethmoid sinuses on the bottom are formed. Their frontal sinuses and their sphenoid sinuses start to develop later on, and the frontal sinuses are not developed right up here till about the age of about 12 years old. So if there's a younger kid who has an upper lid that's swollen, they don't come to me. I always tell my residents, don't come to me saying they have sinusitis. It looks like an orbital. We need a CT scan. There is no frontal sinus there to actually have a sinusitis reaction. It could be something different going on. Same thing as the kid get older. Yeah, if they have upper eyelid swelling, keeping in mind that it could be a sinus infection that's causing the swelling is important to keep in mind. So I like this chart for that reason. Some clinical pearls to take home. Smaller babies and younger children have less immunity. So being very aggressive and vigilant as a pediatric optometrist is very, very important. The infection, their sinus and their tissues, think of them just like paper. The infection can go through that tissues very, very easily. They have to be, for orbital cellulitis, if you ever suspected, hospitalization for IV antibiotics is crucial. Every year at Wills Eye Hospital, we have something called Joe's meeting. It was developed by Joe Calhoun, who was one of the pediatric ophthalmologists way back when. All the ophthalmologists in the area come to that meeting and they share cases. So when one of the doctors who happened to share a case, which I would like to share, is she had I think 2-year-old kid, she said, that was a preceptal. She put the kid on medication, or maybe a 3-year-old, whatever, a young baby, put him on oral medication just like you would. Few hours later, the kid wasn't feeling very well, and they called her, the office, and the office called her, and she called the patient back and said, okay, go to the ER. This is not looking good, so go to the ER. They would need IV antibiotics. Kid made it to the hospital. They started the IV antibiotics, but it was still only like 5-6 hours later, the kid did not make it. The infection had already passed to the brain. So these infections are very, very fast moving infections in some children. It's very crucial to keep that demarcation. My kids who I prescribe with oral medication, the younger ones, I will always give the parent my cell phone so they don't have to go through calling the office, getting in touch with some of my staff. No, you call me directly so I can be more aware. I also make them aware and I say, if this looks worse in the next one day or whatever, you're going to go to the ER and then you just call me. In the interim, it's a weekend and you're seeing on a Saturday a patient who you think you're not sure, preceptal or orbital cellulitis, and you're not sure what to do. There's a medication called Rocephin. It's given intramuscularly. It's a cephalosporin, and it's given in hospitals and in office settings for bacterial infections to avoid it so you don't get a meningitis. So I'll call the pediatrician and I'll say, listen, this is not a full-blown orbital cellulitis that I want to send to the ER, but it's the preceptal that's not looking that great either. So what would you like me to do? Do you want me to just send them to the ER? Would you be able to give them a dose of Rocephin? And I leave it to the pediatrician's discretion. Sometimes the Rocephin is not covered by insurance. So the pediatrician either has to eat that cost up, or they then have to fight with the insurance to why they had to give the Rocephin to the kid and not send them to the ER. But that's their stuff that they can figure out. You as a practitioner can give them that choice and say, hey, it's in between. I'm not quite sure. I gave them the oral medicine, but can you give them 1 shot of Rocephin? And that usually helps. Okay. Moving on here. Hang in there, guys. You guys are great. All right. So 6-year-old male comes in with the red eye for going on for the past few months, not getting better, has used some topical medications before, mom doesn't know what they are, done some warm compresses, gets eczema on and off, otherwise is a healthy boy. And if you look at the eye, you can see some blepharitis going on. Vision is a little impacted in that eye. So I like to treat them with OcuSoft scrubs, lid hygiene, keep the lashes clean, do some baby shampoo cleaning. I sometimes give them bacitracin ointment at night also. So I'll tell them to take the bacitracin ointment on a Q-tip and just kind of like, give a little nice, put them on the lashes. And that helps a lot. In some cases, I even give them a combo medicine if they're really inflamed and they need a little extra something. And of course, artificial tears, if they feel like their eyes feel irritated or gunky, then of course, giving them artificial tears would be good as well. Okay. Some of these kids who have chronic blepharitis, you're trying whatever you have to and nothing's getting better. The conj is always red, so they always have conjunctivitis. They also develop corneal issues, so keratoconjunctivitis. In those kind of kids, I do want to add an oral medication for them. You can give them azithromycin, erythromycin, tetracycline. Again, we talked about tetracycline not given in younger children because of the side effects that we spoke about earlier. Okay. Those of you who've been practicing as much as I have, if you remember way back when, there was not much of eyelid disease or dry eyes, especially in younger children. They had great tear production, things looked good. We almost always thought that dry eyes was a disease for the older population. But now we see them more commonly in younger children as well. And many of it is because of the inflammatory conditions which decrease tear production like Sjogren's or GIA, congenital conditions like familial dysautonomia, where they have no tear production at all. We actually have a pair of siblings that I see at the hospital who have familial dysautonomia. Pure nutrition with vitamin A deficiencies, type 1 diabetes in children up to 7.7% can have dry eyes as well. And I was amazed with that because I was just reading that article a few months ago and I was like, wow, I didn't know that. Kids who are on systemic antihistamines, they decrease lipid production as well, cause the dryness. Environmental causes, I swear after the pandemic, the kids that have been on these iPads and virtual learning and all the above, they have tons of dry eye going on because they decrease blink rate. And if you see my kids playing the Xbox, especially my boys, they're this. Like they don't blink, and I almost am looking at them like, oh my goodness. So yeah, they almost always have dryness in the eyes because of that. How can you actually quantify dryness? It's hard to check in children. We understand that. Schirmer's test is hard to do in kids. I look for overall signs. One, are they rubbing their eyes too much? Do they have redness in the eyes? Some of them will complain of a foreign body sensation. I try to look at it at the slit lamp for a good tear meniscus height. Like, is it looking good? Is it not there at all? Is it decent? So gauging that. Also, in many children, you can do a tear breakup time, at least to see if there's some form of dryness in the eye. Artificial tears are a great option. You can use over-the-counter Refresh tears, Lacrolube. I like those. Sustain is one other choice I like. Again, I don't have any financial disclosures with them. Restasis is used in younger children too, though it's given over age 16. But we use them in younger children as well, based on the adult population, because there are not many studies that are done on kids. You can still use what you gain from the adult population in your younger children. So I think the youngest we do Restasis, I would say probably 13, somewhere around there is what we do, maybe even 12 or so. And then you can add the oral medications that we talked about in these children as well. Okay. Again, a big thing is the atopic eye disease that we're seeing a lot more. I feel like in this last decade or so that I'm noticing more. 20 to 40% of patients who have atopic dermatitis also have the eye disease, like blepharitis, keratoconjunctivitis, keratoconus, herpetic eye disease, cataracts, retinal detachment, and so on. Many of these kids are given antihistamines, mast cell stabilizers. In worst cases, you can put them on steroid eye drops. Tacrolimus ointment is used in some of these kids, the Protopic. It is a skin medication, but it is used as an off-label medication in the eye. Cyclosporin is another medication that's used. It's not FDA approved for atopic disease, but it is FDA approved for vernal and dry eyes. So those are the ones that we would give in these children. The Vercasia is another medication that's more common now to use. It's cyclosporin AC 0.1%. It was FDA approved in 2021. It's given as 4 times a day medication. It does significantly reduce clinical signs and symptoms in the patient's eyes. Some of the side effects are easily manageable. Eye pain is common, but again, I don't see it too often. Some of them complain of itchiness, decreased vision. Systemic side effects from Vercasia could be cough, pharyngitis, but again, the risk of it is very, very minimal. I've been noticing that kids who I need to pre-approve for Vercasia are harder. They have to be pre-approved. All the insurances are not covering it. We do get samples from Verkasia on and off, and there's a program that Verkasia does. It's called the Verkasia support something. You just call them and you fill in a paperwork, and if they qualify, they can give them some samples to help them out. So we usually use that at the hospital. A fair amount of our kids for vernal are using Verkasia, and I'm very happy with how they're working. It's non-steroidal, so instead of them being on a topical steroid for a long time, this medication is a much better option for them, non-steroidal option. Okay. Systemic medication called the Duoxepant is given for atopic dermatitis. It's given for asthma people. It's given for people with eosinophilic esophagitis. The atopic dermatitis group that gets the oral medication Dupixent is the one that causes more of the ocular side effects. It's a monoclonal antibody. It's given as an injection every 2 to 4 weeks. It pro-inflammatory cytokines and chemokines. It blocks their release with the IgE. And its common side effects are conjunctivitis, keratitis, blepharitis, dry eyes, itchiness. And if your patients are on these ocular medications, then on the systemic medication, then you want to watch out for these ocular side effects that you may see with it. There's another group of, I think the medication for this JAK inhibitor is called Rinvoq. It's capitalized letters, RINVOQ. It's commonly used for atopic dermatitis as well. And JAK inhibitors are associated with retinal detachments. So again, if your patients are on any of these medications for atopic dermatitis, you're watching out for the risk of retinal detachments. Okay, so that was summing most of that. Let's move on to
Nidhi, did you put your polling questions into your presentation?
You know what? I did not. I did not put them in. Should I put them in, or should I?
Well, it's okay. We just needed a placeholder. Let's to keep this synchronous. Can we launch one of them, and then maybe a little bit later we'll do another?
Yes, that was my bad. I should have done it. I didn't think of it.
So we have the polling question number 1 up here. Am I skipping, Joe?
Now you're not. You were earlier.
Okay. I unplugged my microphone. I'm trying to unplug this, so we'll see if that helped it. So if a child has penicillin allergy, what class of medication should they avoid because of the risk of cross sensitivity?
It's probably a Zoom quirk, Greg. You're still skipping a little bit. So your microphone is okay.
Okay.
No worries.
And in the poll, I'm going to share the results. Nidhi, you should be able to see them.
Yeah, I do see them. All right. Well, great. Cephalosporins is the right answer, and most of you got that right. Yay. All right. So moving on, Greg, then in between, I might have to tell you to launch another one. So maybe I'll do the dilation, and then we can do another polling question.
Yeah, just keep it in mind. It helps keeps us synchronous and live. So
Absolutely. All right, so let's talk about dilating drops, things that we use commonly. If I can ever get past this slide. I don't know why my screen just goes kaput here. Sorry about this. I can't advance the slide anymore. Am I doing something that I shouldn't be doing?
try clicking on your presentation.
Yeah, for some reason, I think I'm frozen here.
All right, see if we can get unfrozen. I'll do another poll. All right, while you're trying to get unfrozen, we'll do a poll here. Children with GCS 6-PD glucose 6-phosphate dehydrogenase insufficiency should avoid which class of medications to avoid the risk of aplastic anemia? All right, we're going to, they're paying attention on this one. Are you frozen?
Yeah, for some reason I can pull it up here, but as soon as I go to the current slide, I can't do it. Oh, here it is.
All right. So as soon as we get done here, we'll jump back in presentation.
Sounds great.
There you go, the results.
Great. So a lot of you were listening. Great job. That's almost 60%. And the answer is sulfa medicine. Very good. All right. So getting back to our dilating medications, we all use dilating medications on a daily basis. In younger children, I do recommend cyclopleging them, especially for a good refraction. So I'm a big advocate for that. I think I want to share a patient with you. We had one kid who came in, I think she was 2 or 3 years old. We encourage our residents at the hospital to do a dry retinoscopy, even though that might not be the best in younger children. We still like to have them just get used to it. So she comes and tells me, 2-year-old kid has +2 diopters, spherical. I said, oh, great, that's normal for that age group. No worries, good. We cycloplege them like we would. And after we cycloplege them, she was +6. So that gives you more a reason why that I'm a big advocate of dilating and making sure we have a good cycloplegic refraction in younger children. We have a bunch of medications, as you can see here. Homatropine, we don't really use anymore because it's not as easily available. I don't know why I am just not advancing here. It says I'm sharing it. Sorry about this glitch. Don't know what's going on. Okay. Oh, great. Okay. Cyclopentolate gives a good paralysis of the iris muscle, good cycloplegia. It's used in kids with iritis and uveitis. Some of them have side effects like behavioral changes. We avoid them in patients with seizures. We talked about that. Tropicamide gives good mydriasis and cycloplegia as well, not as strong as your cyclopentolate. What else? Phenylephrine, it dilates the eye. In some kids, it can cause stinging, burning, increased heart rate, which is why we watch it. Atropine has become a big topic nowadays. We all know that, those of you especially who do patients with myopic control. Atropine is used in different formularies, as you can see there, in different strengths. The 1%, it dilates the eye and gives cycloplegia. It's used mostly in amblyopia treatment. Kids who don't patch at all, at least it's something that we can do to dilate the eye and maybe force their amblyopic eye to be used. Some of the common side effects could be stinging, burning when they put the drop in, some flushing or photophobia, and decreased lacrimation. Again, very minimal side effects. Myopia control has become a big deal. I do a lot of myopia control in our practice because I see, of course, younger children, who is why we are doing all this myopia control. I tend to use the atropine eye drops, 0.01% is many times where I start. And then sometimes I'll do the 0.02% or the 0.05% as well. The reason why we want to make sure we do that is this slide gives us a whole different idea. The prevalence of myopia is increasing globally. So by 2050, it's expected that 50% of the population will be myopic. That's 4.76 billion people who are going to be myopic, which is great because we won't be out of our job. But at the same time, we know that that's not the best thing for our young children to develop. They come with higher myopia, comes with its own abnormalities, the optic nerve, optic disc abnormalities. You have glaucoma risk, peripapillary atrophy, chorioretinal atrophy, retinal detachments, maculopathy, and so on. So based on this LAMP study that was done, again, you can use any of those percentages. I normally start with 0.01. In some kids who are still showing those myopic jumps, I move on to either 0.02 or 0.05 if they are dark-eyed patients. It's not FDA approved for this, for myopia control. So unfortunately, the insurances don't cover it and patients pay out of pocket. In our area, Philadelphia and New Jersey, they cost almost anywhere between $70 to about $100 for 1 month supply. So a lot of it is money-based. Again, a lot of parents do it and many don't as well. So for the babies less than 1 year old, I like to use cyclopentolate 0.5% or a combo of cyclomidriasil. Again, if they have light eyes, you can just get away with cyclopentolate. If they are darker eyes, I use a combo of cyclopentolate and tropicamide just to give that little extra edge for dark-eyed babies. Okay, hopefully I won't get stuck this time. I'm going to cross my fingers. Okay, now we're good. All right. A 7-year-old comes in to rule out amblyopia because she failed an eye exam at PEDS. A lot of our referrals for us come from pediatricians, thanks to our pediatricians. The office, we are a 5-doctor practice. We have 3 pediatric ophthalmologists and 2 pediatric optometrists, including myself. And we get referrals from almost 250 pediatricians in the area. So a lot of our practice is dependent on our pediatricians. So you'll see a lot of me saying they were sent by their pediatrician. All right, nothing else going on with this kiddo. 20, very poor vision, 20/200 in one eye, 20/80 in the other eye. And when you look at the slit lamp, she's got uveitis going on, iritis, mild cataract in the right eye, which is why her vision is a little more affected in the right eye. The back of the eye looks fine. Because this uveitis is bilateral, so we're going to have a full systemic workup done with rheumatology, possibly for juvenile idiopathic arthritis being on the top of my list. Of course, there's way many other things that can be affecting and causing it too, but that would be the most common one that you can have. So put the kid on Pred Forte every 2 hours in both eyes, cyclopentolate in both eyes as well. Let's talk about topical steroids. Ketone-based steroids like the prednisolone and the dexamethasone, and they are ester-based steroids like the lodoprednol. Human body has a lot of esterases in the body, but no ketones in the body. Remember, our human body has steroids in the body. The ketone-based steroids, they linger in the tissues longer, so they give great therapeusis. But because they linger on in the tissues a lot more, they cause the risk for developing cataracts and glaucoma with long-term use, right? We all know that. Ester-based steroids give great anti-inflammatory effect, but the enzymatic degradation of that steroid occurs because we normally have esterases in the body, and that's why they have less potential for side effects with it. So that's kind of why we have that the lodoprednol and those soft steroids don't give us much issues like our prednisolone and the dexamethasone do. I just listed out our topical steroids, Durezol being the most potent, and then going down the list over there with FML being not as strong. We have combination steroids with antibiotics, the Tobrudex, which has tobramycin and dexamethasone. Usually that's my go-to, is I like Tobrudex because it has tobramycin, which is not my favorite, but out of all the 3, it is the one that I like. Right now, I don't know about where you are, but in our areas, Tobrudex is super expensive and insurance is not covering it. So a lot of my patients, we end up giving Maxitrol if I have to. Again, neomycin is not my favorite out of that group of aminoglycosides, but at the same time, it is the one that I've been using since Tobrudex has been so expensive and insurance is not covering it. We all know steroid use is for iritis, episcleritis, chemical traumas, corneal infiltrates, VKC, stromal keratitis, uveitic glaucoma, and post-operative care as well. The contraindications are you don't want to use it if you're suspecting herpes simplex infection, acute bacterial infections, but in those cases, you could give a combination medicine. If they have significant epithelial compromise, you first want to heal the epithelium before you give them a steroid. And of course, in fungal and mycobacterial infections. Don't forget to tell your patients to shake the bottle, which many times they do forget. And we always want to taper steroids, and we'll talk about that actually. Oral steroids, most of the time, I have never needed to prescribe oral steroids to anybody because by the time most of the kids need the oral steroids, I'm usually co-managing with the retina doctor or our pediatric ophthalmologist or the pediatrician for something. So most of the time they're already on it and I'm just watching them to make sure they don't have any eye side effects from it. But I don't really necessarily ever have prescribed it in the younger children population. The oral steroids bind to intracellular steroid receptors and modifies the gene expression and the protein synthesis. So they overall cause a non-specific immune response suppression. And we know that they suppress the immunity. They're commonly used in pediatrics and asthma for poison ivy, croup, allergies, autoimmune diseases. They have side effects that they come with: slowing of growth, weight gain, worsening of diabetes, worsening of peptic ulcers, and a reduced ability to fight off infections in the younger children. Their ocular risk, we all know they have risk for causing cataract, and in some studies to about even 38.7%, and many of them to about even 31.5% can be steroid responders or cause the risk for glaucoma if untreated or unlooked at. Key point to remember, pediatric steroid-induced glaucoma is there. Kids have exaggerated pressure response to steroids. And again, the cause of it is they think is because structurally and functionally, there's immaturity of the trabecular meshwork. So that's kind of why they have exaggerated pressure response in younger children. Their glaucomatous damage is more earlier onset compared to adults. So if you're putting them on oral steroids or topical steroids for a longer period of time, be aware that they're the ones who can definitely develop glaucoma more rapidly than adults. I just broke this down into long-term use of oral steroids. They can cause ocular hypertension even as early as 1 week of use. A lot of them develop them in the first year of use. Most of this is dose dependent. So if they're using less than 5 milligrams per day, you're less likely to have the side effects. Of course, if they use more than 10 milligrams per day, you're going to have more risk of having ocular side effects from the oral steroids. All right. So I know that we all have this grinded in our mind that we should taper steroids, and many of us know why, and many of us were not paying attention when pharmacology was going on back in the school. So I just wanted to review that for those of us who enjoyed that side of it. So it is a negative feedback that causes, and that is why we should be tapering steroids. The hypothalamus produces the corticotrophic releasing factor, the CRF. This travels to the anterior pituitary and triggers the ACTH, or the adrenocorticotrophic hormone. This causes the adrenal cortex to upregulate the production of the natural steroids like hydrocortisone and corticosterone. And when the levels of natural steroids in the plasma increases, the ACTH decreases, and this kind of negative feedback maintains the normal homeostasis in our body of natural steroids. Now, when you give synthetic steroids or oral steroids to a person over a longer period of time, that adrenal cortex, it's slowing its production of physiological steroids. It's not going to do the work. So when we taper steroids, we're telling the adrenal cortex, come on, it's time to start producing your own normal natural steroids. If we stop the steroid abruptly, you're not giving that body the time to make their own steroid, so the body can go into hypertension and hypoglycemic levels, which is not great. This can result in atrophy of the adrenal cortex and even suppression of the pituitary function. And that's why it's important to make sure that we taper the steroids. Definitely more for systemic steroids rather than topical steroids, which we still taper both of them. But this was more for the oral steroids that we talked about earlier. Right. Greg, why don't we do another polling question then?
Sounds good. So tetracycline is not administered in children less than 12 because, and Nidhi, I did add a polling question while we were sitting here. At some point, I'm curious to see the audience who's doing myopia control, you're controlling it. So when you need a break, I'd like to see that. Joe and I were recently at a lecture commented because of this kind of the new pandemic myopia within the eye world, maybe suggesting to children at least the option to the parent that there's myopia control.
Yeah.
Okay, here we go.
Wonderful. 80% of you got that right. That's absolutely perfect. Now I'm going to cross my fingers because every time the polling question comes up, my screen freezes. So let's cross my finger. All right. A 7-year-old male comes in my case, Peds referred them because of some vesicles around the eye. It started 2 days ago. This happened after the baby was sick for a week. And of course it froze again. So give me a second. Take a breather here. I knew it. I don't know what that polling question does to it. It just stops. Okay. All right, I'm gonna go back here really quick. See if that pulls it up. Okay. Oh, there we go. All right, so we can see this kid has herpetic eyelid lesions with the dendritic lesions on the epithelium. That's a very classic textbook appearance. You and I know that that's not many times how they look. So this is a very nice picture of the dendrite. There are many times that the dendrite doesn't look like that. Topical medications like Zergen gel, I would give to the eye if the eye wasn't affected. Many times, if the eyelid is only affected and there's no eye activity, no conjunctivitis, no cornea involvement, I don't put them on any eye medication inside the eye because these antivirals are very toxic to the epithelium. So I don't need those babies to have these on them if it's not necessary. If they do, of course, we give them if they have issues. Otherwise, just doing the oral acyclovir is all that we do for them. Herpes simplex is common virus affecting humans. There are two types. You have type 1, that's from direct contact. Then it goes to the peripheral sensory nerves, to the trigeminal ganglion, where it stays latent and then reactivates because of trauma, atopic disease, diabetes, immunocompromised kids, stress. And then you have type 2, which are from genital infections. You can have totally different presentations. Many include tearing, decreased vision, photophobia, burning, eyelid blisters, like we saw vesicles on that kid, conjunctival redness, cornea. You can have epithelial, stromal, or endothelial disease. Herpes HSV is one of the leading cause of blindness globally. It is very hard to diagnose, and that's probably why it is the leading cause, one of the leading causes. Kids at any age can be infected with it. Newborns are infected. So a story to share with that is a good friend of mine, actually, many years ago when I had my little one, she was pregnant with her baby as well. And she had them a few months after I had my little guy. Family went to the hospital. This was way, way long ago before COVID hit. They went to the hospital to see the baby. Everybody looked at the baby, and then the baby fell sick that night, and the baby passed the next morning. So question was, when they looked at what had happened, one of the aunts had a cold sore who kissed the baby, and that's triggered the whole immunity response, and then the kid just had encephalitis and passed. So coming back to this, newborns can be spread through as little as a cold sore. Kids have poor immunity. It can go through their CNS very quickly and their organs and be life-threatening. So no kissing the little ones in general. I don't think that's needed, especially if you're not feeling well. In younger children, if you suspect herpes in little babies, you have to send them to the ER because they need to be hospitalized for IV antivirals. By the time the oral antivirals go through their body, this I'm talking about the really little ones, it takes longer for that to work. So it's better to get them IV antivirals in the hospital and then probably send them home with oral antivirals later on. But that's an important part. Their tissues are very, very easy to go through. Children develop severe disease manifestations, again, because they have increased inflammatory response. You can have bilateral cases in HSV as well, up to 26%. Frequent recurrences are common in children. Corneal stromal scarring is common in children as well. Again, my radar goes up for amblyogenic factors, so keep that in mind when you see these kids getting recurrent, frequent recurrences, because their cornea can definitely be scarred, and that can cause deprivational amblyopia risk or refractive amblyopia, especially every time they have some changes in their cornea, they can have induced astigmatism. Zoster is also seen in children, but it's not as common. The hepatic eye disease study is done for over 12-year-olds. So in my mind, it's almost an adult-like. They just show you that in epithelial disease, give them oral acyclovir. Non-necrotizing, you can give topical steroids with it. A necrotizing stromal keratitis, don't give them steroids. And in recurrences, we do put kids on a maintenance medication. In my population of children, when we do put them on maintenance, we're not putting them on a bigger dose, probably 50 milligram to 75 milligram every day while they are sick. When they feel better, they stop the medication. So we don't use it for them on a longer period of time. After the first episode, some of these kids have 50% risk for having a second one within a year. And after the second one, they have almost 70% of risk for the third one. So I always educate my parents and say, listen, if you have a red eye, I don't want you to sit on it and think it's just something, no big deal. Once you've had that herpetic disease, there is the possibility of a recurrence. You need to come to see us right away so we can make sure there's nothing going on with the eye. Viroptic used to be used way back when. Now you have Zorgan gel, which works great because it can be given only 5 times a day till the ulcer heals, and then you give it 3 times a day for a week. You can use it in younger children, which is wonderful. Oral acyclovir is our go-to oral antiviral in children. The Valtrex and famciclovir are really for older children. So our go-to in the younger population is oral acyclovir. Don't forget to educate your adults or your kids to drink lots of water. It flushes out through the kidneys. So drinking lots of water to flush it out will only help their kidneys. Right. Greg, while this comes up, did you want to do that myopia control poll that you were thinking?
Well, let's run it, and then maybe it's the last one if it freezes you up.
Okay.
I'm just curious. Yeah. Who's doing myopia control? I'm doing, yes or no. I discuss myopia control options, yes or no. At the European Academy of Optometry and Optics in early May. It was in Poznan, Poland, and this was a huge topic of the conference. All right, we got a nice response. So there you go, Nidhi.
Wow, a lot of you discuss it, but a lot of you don't do it. Well, I do a ton of it. I also do my sight lenses. That's a whole lecture in itself to talk about myopia control, so we're not going to discuss that much. But yeah, I do a lot of it. So that's great to know that a lot of you discuss it, which is, I think, the first step to at least giving them the information out there. So I think that's great.
Great, I agree. It's catching on in the United States, and good to discuss it. And more and more people will continue to do it.
Right. All right. 10-year-old here for a 3 to 4 month follow-up with JIA. We see them. Remember with JIA, the kids have white eyes. They're not going to have your uveitic kind of changes, flares, painful eye, redness. No, GIA kids who have uveitis, flares in the eyes are called wide eyes. So you're going to have to follow them more closely to make sure they don't have any uveitic changes in their eyes. It is on methotrexate, which is usually the go-to for GIA patients, and they see their rheumatologist pretty frequently.
All right, Nidhi, I think you're having the Greg Caldwell effect here. You're getting a lot of feedback. Let's see. Try now speaking. It was your voice. It wasn't your slides.
Okay. Slide wasn't coming up either, so let's see if this works. I'm gonna go back a little bit. Does that help?
Yeah, you're still got that feedback.
I don't have anything going on. All right, to go slowly, maybe. So this kid has with glasses, 130 one eye, 230 minus 2 in the other eye, 2 plus cells and flare.
Nidhi, we're getting a lot of interference here.
So Nidhi, what I would recommend is log off. You're not gonna, and come back on, and I'll run another poll while you're doing that.
Okay, so
Joe, watch for it to come back in, please. Okay, which drug is likely to be epithelial toxic to the cornea? Perfect. Okay, we're gonna end the poll. I'll share the results. And that is correct. The gentamicin, very toxic to the epithelium. That's out there. And Glenn fell for the sustain trick. Joe, you have any comments on gentamicin and these antibiotics being toxic?
Well, I want to bring her back. Yeah, I actually, for the first time in years, came across a patient who was prescribed an ER gentamicin. I've not seen that for I don't know how many years. I think maybe his patient's physician had been doing a hard time before that.
There you go.
But
Nidhi, you're back. Yeah, can you speak? Nidhi, can you say something to see if your voice is fixed?
yeah, is it better?
Yes.
Perfect. Okay.
That's all it was. Holy mow, all these little stuff. All right, sorry about that, guys. I
No
missed you.
worries.
Hopefully you missed me while I was gone. All right, so back to work here. Okay, kid comes in with vision with glasses, 20/30 in one eye, 20/30 minus 2 in the other eye. We were talking about a patient who had JIA. Of course, they have a uveitic flare in their eye. So refraction is -2, but no improvement in either eye. Nothing going on in the posterior pole. They have uveitis secondary to the JIA. So I put them on Pred Forte 6 times a day. You could do it every 2 hours. You could do it every hour. That doesn't matter. It's whatever you think you want to do. In the night, like I said, I usually do ointment coverage. So I added FML in the night. Added cyclopentolate twice a day. And if your pharmacies don't have the cyclopentolate, which sometimes ours don't, then we put them on atropine once a day. And then you follow them back in a week or 2. First case scenario, the anterior segment looks great. The flare and the cells are getting better. You continue everything, follow them again. clinical pearl to give you, JIA, the uveitis lingers longer, so taper slowly. That way we can make sure that it doesn't recur and doesn't affect vision. So in JIA patients, make sure when you're tapering off their steroids, you're using longer taper for them. Now the PIDS comes in and their cells and flare are much worse. What am I going to do? The first question to ask them, have you been using your medication, right? That's important to know. Some of them, we had a patient who came in, they have glaucoma. I was checking their pressure was high. My first question was, are you using the medication? Yes, I'm using. Did you use it this morning? No, I didn't. Well, I want to see what your pressure is when you're using the medication. So again, little housekeeping things that sometimes the patients don't remember. I increased the Pred Forte for this kid because they were getting worse. Still FML at night, cycloplegia them. They started to show some signs. Look for any signs of posterior uveitis. Check IOP because they're going to be on this medication for a little longer. And if the uveitis is recurrent on methotrexate and you're not able to taper off their medication, or you're able to taper off the steroid, but they get a recurrence soon enough, then that's the time you want to call the rheumatologist and say, listen, they've been on the medication for a bit now, and this methotrexate might be helping their systemic disease, but it's definitely not helping their eyes. I would think we should switch them to Humira or use it in combo with methotrexate. And then the rheumatologist can go ahead and do that. There are a lot of research that's proven that methotrexate, Humira is a great medication to use for the treatment of patients who have this uveitis that just doesn't go away. Keep an eye on them. It takes a few weeks for the Humira to kick in. Sometimes during that time, the uveitis can get worse. In those cases, some doctors switch to using Durezol, so you can kind of, help with the inflammation. Some of them just push through the Pred Forte more often, every half an hour, every hour. Maybe add a small dose of oral prednisolone during that time to help with any posterior vitritis that might be going on at the time. But once the Humira kicks in, mostly these kids do better. So they've had 2 doses of Humira, uveitis is looking better, but hello, the pressure has also gone up because we did use Durezol for a little bit. We're using the Pred Forte more frequently, so that's common to see in these kids. That brings us right into the topical glaucoma medicines. Beta blockers are a great medication to use. They do help with reducing intraocular pressure. You want to use them in caution with asthmatic patients and cardiopulmonary disease patients. Prostaglandins like Xalatan is a great option as well. It can cause long lashes, increased iris pigment. The Vyzulta is a new medication on the block. You have Travatan, Lumigan. They also help with decreasing intraocular pressure. Vyzulta was FDA approved in 2017. It's a latanoprostene with nitric oxide. And it's the mechanism is basically based on the fact that it increases the permeability of the trabecular meshwork. And that's the idea behind it. In some kids who are using Xalatan, we actually switch them out and then use Vyzulta instead, just to see if that helps them better. It's used once a night, and it can be used in younger children. Again, remember, just because we don't have data that is FDA approved for younger children, we use the adult data to kind of simulate the same scenario in our younger children population. Some of these kids will complain of conjunctival hyperemia, eye irritation, same idea, lash growth, iris hyperpigmentation, intraocular inflammation, or macular edema as well. Carbonic anhydrase inhibitors are great as well. Drozolamide, brinzolamide is a great medication to use as well. Your alpha adrenergic agonist like brimonidine is good. It is used as a standalone therapy, or it is used as a combination medication with the other medications too. Repressa is a great medication to use as wet. It's nitarsodil ophthalmic solution. It was back FDA approved in 2017 as well. It causes reduction of elevated IOP in patients with open angle glaucoma or ocular hypertension. It's given once a day. You have some side effects like hyperemia and vortex keratopathy. Now, if you see vortex keratopathy in kids or adults, you want to look for 3 things. One, are they on Repressa, which I see in our kids on Repressa. Almost till about 3 months later, if they've been on Repressa, they can show the signs of vortex keratopathy. Two, are these people taking oral amiodarone for their cardiovascular issues? Or three, Fabry's disease. That's the other thing you want to keep in mind. So vortex keratopathy, three things associated with them. Repressa is used in combination with other drops. So when we use our patients in glaucoma at the hospital, I know I work with our glaucoma doctors. We start them off with combination glaucoma medicines. If COSOPT is more common that we use, then we add a prostaglandin to it. Then we say, okay, should we add a carbonic anhydrase inhibitor or brimonidine or so? If none of those work, then we usually say, okay, let's add Repressa to it, or maybe change the prostaglandin to the Vyzulta, and then we go back and forth to see if they help any of the kids. The idea with kids is to see if we can hopefully stall them before they need a procedure. That's usually the idea behind it. Our glaucoma doctors don't really prescribe much of the oral glaucoma medications in children because of their side effects that come with it, especially the tiredness. So our kids are not usually on it. I know there are some other glaucoma doctors that I work with in Jersey that actually do give them. Again, I think it's very common to see them based on each doctor's perspective. But at the hospital, they don't do that too often. So coming back to our GIA patient, we put them on COSOPT, and then you kind of monitor the pressure from there. Let's have a brief look at pediatric glaucoma. There are different kinds. You have congenital glaucoma at birth. Infantile glaucoma is also something that develops in the first year or two of life. Juvenile glaucoma develops after the age of 3. And then there are some syndromes that are associated with glaucoma, like Sturge-Weber syndrome. You have Axenfeld-Rieger syndrome, aniridia, and aphakia. Now, I do a lot of aphakic fittings at the hospital I work with 3 or 4 surgeons who do cataract removals, and then I work with them for aphakic fittings. So I do almost 50 to 70 contact lens fittings a year for aphakia. You want to watch these kids because they are at a lifelong risk for aphakic glaucoma. So I usually see them every 3 to 4 months and monitor their pressure to make sure that they don't develop the aphakic glaucoma. And if they do, then obviously you want to manage it. So we talked about kids with aniridia. All right, I see that we have about 10 minutes, so let's go through some important stuff. Congenital glaucoma, you have excessive tearing, a larger cornea, a cloudier cornea. So make sure you keep those signs and symptoms in mind. I love this when our residents come and say, I think the patient has glaucoma. The kid has discharge going on, matting of the eyelashes going on, lots of tearing going on, and they focus only on the tearing part of it. And I have to consistently remind them that tearing is one of the byproducts, but if you've got discharge going on, not necessarily glaucoma going on. So you got to be aware of that scenario. Can they go together? You can have an infection if you're having glaucoma. Yes. But again, you want to look at other signs and symptoms as well. And again, we talked about that if the medications don't work, sometimes these kids end up with surgical procedures like trabeculectomy and goniotomy. Do you want to do another poll, Greg, or should I just finish up the last few slides?
No, go ahead. Go ahead and finish up the slides.
Okay. So our topical antihistamines, most of them are over the counter, which is great. We don't really have to worry about those. They're a combination of mast cell stabilizer and the antihistamines. I love all these drops and most of the patients get them. So if the kid has seasonal allergies, let's go here. I would put them on an antihistamine. Put them on a soft steroid like an Alrex or Lotamax, which is, again, not being covered by insurance lately. You have to fight for it. So I put them on even Predforte for a very short time if they're really, really inflamed and are having a hard time with it. Don't forget oral antihistamines. The eyes can only work so much with the eye drops. You want to make sure that your patient definitely uses oral antihistamine as well. So a couple of cautions: isopropyl alcohol is not used in neonates because it can cause chemical burns. Gentamicin can cause severe anterior segment inflammation. Brimonidine is not used in kids less than a year or two because they can cause respiratory depression. Tetracyclines we talked about. Aspirin is not used in younger children for the risk of Rey syndrome. There was this study that was done by the colleagues at CHOP, and when erythromycin ointment that's used for neonatal conjunctivitis was on back order, and they were using gentamicin in the hospital at that time, they saw periocular ulcerative dermatitis that was associated with the gentamicin. That's why it's not my favorite medicine. But again, in push come to shove, if you have nothing else, you can definitely use it. Quick recap on this: the catheter drugs that are used for cystic fibrosis can cause cataracts. That's important in them. They can cause cataracts. Targeted chemotherapy drugs are also used and can cause dilated pupils. They can cause periorbital edema. So the targeted chemotherapy drugs, if your patients are on, you're looking for these signs and symptoms. They can cause photophobia, accommodative problems. These are all targeted medications. Tyrosine kinase inhibitors that are used in leukemias, they can also cause side effects like conjunctivitis, keratitis, photophobia, and blurred vision. The BRAF inhibitors or the MEK inhibitors that are used for CNS tumors, they can cause conjunctivitis and uveitis as well. And the MEK inhibitors can cause macular edema and serous retinopathy. The vigabatrin is Sabril. It's used as an anti-epileptic drug. And these are associated with, again, dose dependent, they're associated with ocular toxicity. So that's vigabatrin. What else? Plaquenil is another medication that we use in malaria, dermatomyositis, that can cause bullseye maculopathy. So that's something to remember. And Topamax, which is nowadays used for migraines, seizures, off-label weight loss, can cause a myopic shift in refractive error, angle closure, glaucoma, and ocular pain. And thanks for hanging out. If you have any questions, feel free to let us know. Otherwise, thanks again, guys. It was such an honor.
Nidhi, there was a question earlier. And the question was, any correlation with pediatric conditions and vitamin D3 levels below 70?
Say that again, I'm sorry.
Any correlation with pediatric conditions and vitamin D levels under 70? Low vitamin D.
Vitamin D. If there is, I don't know the answer to it.
Okay.
I don't normally see kids who have vitamin D levels that are low enough to cause an issue, but I can look into it and see if there is. At top of my head, I don't know if there's any correlation.
Okay, very good.
In one comment, if you want to stop so I can put up the final slides, that'd be great, Nidhi. One comment I'll make regarding the antihistamines, the oral antihistamines. I was by Tracy Offerdahl, who I lecture with. For the audience that's out there, is I remember ZAC, Z-A-C, Zyrtec, Allegra, and Claritin. If you remember Claritin Clear, Claritin is the weakest. Giving you the Zyrtec is the strongest. Xyzal is a prodrug of Zyrtec. So Xyzal and Zyrtec are the strongest. Then Allegra is in the middle, and Claritin, just remember Claritin Clear is the weakest, and then you'll kind of remember. So if you're looking to give someone an antihistamine, that a weak, go Claritin. If you think something strong, Zyrtec, Xyzal, something in between, go Allegra. So
Good point. Yeah, I remember actually you had mentioned that in one of your previous lectures.
Nidhi, another question came in, I think for our final question. I think I just lost it. How long on average do you keep children on low dose atropine for myopia control? Greater than 2 years old.
Oh, that's a great question. I tend to prescribe the medication more in their growth phase. So more kids who are like 7 and older, unless they have like very high myopia when they're younger. How long do I keep them? I think it's that growth phase question. few years, definitely, with some trickle off from the bandwagon because they're expensive and they can't keep up with the money. But if we could, I had my daughter on it for almost 4 years because she's highly myopic. So I had done it for her for a few years. So that would be what I would do.
Very good.
And then I did do the polling question while you were talking, Nidhi. There's the results if you want to see them.
That's great. You guys listened. Yay.
All right, everyone. Well, thanks for attending. Joe, if I'm breaking up, I'm going to let you run through the slides. So we went through the questions. Thanks, everyone, for attending. This was Pediatric Pharmapalooza by Dr. Nidhi Rana. Thank you very much, Nidhi. Nidhi, you did a great job. Thanks.
Thank you.